of like intertwined. Like you can use it to, you want to still screen depression, because it can mimic dementia or Alzheimer's. Well, Alzheimer's is dementia. Um, and then the MMSE, that one's just gonna screen for cognitive. So that one you do use it for dementia, okay? So just understand those two, and then you should be dandy. Pharmacological treatment for dementia. Know that none of the treatments that she discussed stop the malfunction and death of neurons. It will only slow it down, okay? That's really important because, if someone's family member asks, like, okay, well, you need to give them education on it. This is good to understand too, so you understand the medication. Know your drug of choice, know the signs and symptoms. So, remember this, but if she asks for a drug of choice, it's cholinergics, it's a drug of choice, the dinoxapril. I think she gives you both, so that's easy. This one's for all stages, okay? And then these are the signs and symptoms. Honestly, just think GI, nausea, vomiting, diarrhea, easy peasy. Amantine, she gives you both, so that's really nice. Um, and the mechanism of action, so what it does, okay? Uh, what else? Again, dementia is not a normal sign of aging process. There's 7 stages of dementia. Our focus is to recognize early and late. So there it goes. So I would, if you don't know the late stages, just go over it pretty quickly. But honestly, it's at first they're just forgetful, and then later it's a little bit more worrisome because um, suicide risk increases, and then they start losing again like a lot of their function, so loss of speech, words, major memory gaps, and then ADLs. So that's like important. um yeah, see, final steps, like they can't just know, it's like if they can't do anything, that's probably late dementia. Okay, seizure disorders. Let's see. Causes, you want to know what is going to cause the seizures? These are like the 4 most common. Whoa, I don't know what happened here, but I hope that's readable. Anyways, I don't think that's just for your information. I don't think that goes into anything. Mostly know what to do with a patient that is having a seizure, okay? You don't put anything in their mouth. That's like the number one thing. Um, kind of have an idea what each of these look like. Um, yeah, I kind of just bolded like the main ones. And then nursing intervention. So what are you going to do if your patient seizing? Number one thing is safety. So you're going to look at respiration, so like their abdomen. And then post-seizure, they might have a headache, they might be sore, sleepy, confused. You want to reorient them, watch airway, and then they may be anxious because they just woke up, they don't know what happened to them. Or sometimes, depending on the seizure, they are aware. And you want to assist them with their ADLs. That's like the key point, okay? I would for sure know, I don't remember too much being on the medication, but this was the most effective, so she might, these with the stars, Keppra, she talked about them a lot. Um, so I think if anything, you can wear those. Gabapentin, that's anticonvulsant, okay? So yeah. I would still like kind of review the meds. You never know. Phases, definitely know that. Okay. The aura, the beginning, they're like the funny feeling, the burning odor, hand twitching, ictal, so that's like the active seizure. Um, anyone know what you do if your patient starts seizing? So safety. Safety, you always want to like remove anything if they're in the bed, lower the bed. Remove anything that's like they can like hit themselves on. Don't ever restrain your patient. You want to note the time it started and then get help, okay? Don't ever leave your patient. Use the call light. Okay. Nursing priority, prevent injury, OC. Here it is. And then IV meds. Okay. You should know those. This is what you're gonna do to. So honestly, this is really good to review all of this. Like you really want to know what to do when your patient's seizing. But those two are priority. Um, Medication nursing intervention. So during the seizure, you're going to give benzos, so Ativan or lorazepam. That's the drug of choice. Tonic-clonic, you want to give Dilantin. It does have a narrow therapeutic index, okay? So that's why it's not like the drug of choice because you have to monitor for toxicity too. Um, Generalized seizures. I don't think she goes too hard on that one. It's not that I remember. Honestly, all of this stuff is like easy peasy. Like she doesn't go too hard on it. Like she already quizzed you on it. Um, let's take a look. Dilantin, because that one has a lot of like um I would know what's in red here for Dilantin, because it treats all of them except for one. So except absence seizures. The dosage is individualized and it's generally less sedating, okay? Um, Dang, I should have like made this nicer. Considerations, you want to educate, especially with Dilantin, you guys will see this often. Good oral care. You don't want to take it with milk, okay? It affects the absorption of it. Don't skip doses because it's going to trigger more seizures. All this stuff, okay? And then this is huge. The gingival hyperplasia, it's like the gum overgrowth. I would know that, and you'll see that often. And then monitor toxicity. So if there's a skin rash, that's like not a good sign, okay? What else? I don't think really anything from here, but again, anything that's on here, just it's a quick review, honestly. Anything in red you might want to look over. Okay, now moving on to EKGs and coronary artery disease. This is going to be three questions again. ECG basics. You guys are going to see EKGs next quarter too, so learn to love them. Um, all she wants you to know is depolarization and repolarization, okay? The way I remembered it is DDR, okay? So depolarization, depolarization, repolarization, okay? And then the P wave, that's your atria contracting, right? PR is gonna be, oh, you don't even need to know. All she wants you to really know, wait, I think she already quizzed you on this for exam one. So I think the ST segment, but you know what? I remember there being like a question. So if she gives you a question about asking you which one starts, like the pumping phase, that's the P wave, okay? If it's asking you which one, like the blood is going into the body, like pushing, that's the QRS. So note that. Um, any ST segment elevation or any changes to ST, that's gonna be like a MI or something, okay? Um, all of this, I don't think she goes, yeah. So kind of pay attention to like this. Um, Understand what goes on in each one, I would say. Okay. Because I remember there being a question. If you already got the question, then you got it. But she may ask you like point, like drop your pin on the P wave or something easy like that. Or she can ask you the P wave, like the P wave is this, and that's atrial, and then QRS is ventricular. Your ventricles are contracting, okay? Coronary artery disease, the most common cause is atherosclerosis. Um, Risk factor mainly is like hyperlipidemia. Honestly, we kind of know the non-modifiable, and then the modifiable ones, like they all kind of are pretty similar, right? The new one is like the hyperlipidemia. Okay, so and that's gonna be like your cholesterol, all of that stuff. Um, I don't really think you need to memorize these values. Just understand like the total. Like if it you want it less than 200, okay? Um, It says values to know, but that's just good to know. But I don't think she quiz. I don't remember her quizzing you too hard on that. Angina for sure. That's just fanciness for chest pain. Know the signs and symptoms, okay? Know they're gonna do like the Levine sign, all of that stuff. Um, know what it looks like. They're gonna say their chest is heavy, tightness, shortness of breath, diaphoresis, or pain or discomfort. And pay attention to this stuff. Like if she describes it like that radiates to the left side, you want to look out for that, okay? Um, what else? Types of angina. Oh, know what you're gonna know what to do, please. If it's stable, you give the nitro. Okay, so understand when you give nitro and when you don't. Nitro when you're stable. Okay. Um, if pain is, know when to call 911 too. Um, I'm trying to remember. Sorry, guys. Nursing interventions. Obviously, if it's due to like activity, you want to have them stop. You want to have them rest, preferably in high fallers. You're probably going to need O2 therapy, like oxygen. It's probably going to be greater than 2 liters. You want to do vital signs, you want to notify the MD. Um, if you know that a patient is coming in with chest pain or the patient presents with chest pain, you're gonna do a stat 12 lead EKG, okay? What you're doing is you're assessing to see if they're having like a MI, okay? So, and then STEMI or not. Oh, I don't think you guys know about non-STEMI yet. No, maybe you guys do. Um, yeah, so this is what you're gonna do if your patient presents. So I would know that. Um, okay, no congestive heart failure. Let's take a look. Oh yeah, so look at the signs and symptoms for MI, okay? Mona, this was on there, remember? Um, it's an easy test question, honestly. What are you gonna do? Morphine. Know what order you're gonna do it in, okay? Just because it's in Mona doesn't mean that you're gonna do it in that particular order, okay? You're always gonna look at how the patient is presenting. So maybe you're gonna give O2 first instead of the morphine, okay? So just be aware of that. That just because it's listed as Mona, you don't always go in that particular order. Um, STEMI elevation, you're gonna see that on the ECG. Know that that's like any in the again going back to the ECGs. This is where you would see it on like the ST right after the QRS. Labs for heart, know your labs, okay, guys? Heart failure is troponin, okay? There's cardiac markers, which is all your cardiac panels. So it's troponin, CK, MB, like BNP, all of those are cardiac, right? But specifically for heart failure, it's troponin. It's gonna be high, okay? That's the gold standard. I would like really know this. Troponin is for heart failure. You know what, McKenna? I'm gonna check because BNP, I'm sorry. This is for STEMI. I'm talking too fast. You know I'm tired. I for MI, let me see. Oh yeah, it's back here. You know what? These notes are old. Let me look. 1 second, guys. Let me actually look at my current notes because you guys will go over this next quarter too. Thank you for that. Yeah, you guys always fact check me because these notes are not recent. Oh, thank you. Girl, you know I'm tired. I can't wait for this quarter to end. Okay. You're right, it's here. Oh my gosh. Okay. But Really, see what I mean? Like it's easy to get confused. Know which lab corresponds with which disease, okay? Especially for cardiac. Gold standard for MI. No, seriously, me too. I'm done. I'm done, you guys. Okay, treatment. I would, you do the PCI, post care. You know, she loves interventions, and part of your nursing interventions would be like after this surgery is what are you gonna do? Okay, what are you gonna look for? You're gonna monitor for any hematoma, hypertension. You're gonna monitor the pulses distally from the location. Okay, you're checking for perfusion. And then bed rest, more than 6 hours, pressure dressing. I don't think she like goes too hard into this. This is dumb. But you will see this next year. Next quarter. And then oh my Lord. Instruct patient to report pain and bleeding signs immediately, okay? Also know what that looks like if it's serosanguinous and sanguinous, know the difference between those two, okay? One's normal, one's not. For cabbage, I don't remember that being on there. And then heart failure, what it is, unable to pump blood. Okay. There is like systolic, diastolic, and then right and left heart failure. Oh yes, know that heart failure doesn't mean that heart has stopped or failed. Okay. Um, again, your gold standard is BNP. So know your this is like important, okay? Key. Um, I would know what cardiac output is. I don't know why this is red. This should not be red. My bad. What else? I think, yeah, know what cardiac. I think it's like an easy question, like something about cardiac output is. Don't confuse it with like preload or afterload, though, okay, guys? Like if she asks you for cardiac output, like know what it means. That's an easy test question. Um, Left or right? I don't think she goes too crazy. Well, these, what's crazy is these notes. My bad. Holy ears are still able to see them. I would go over like just understand what left and right heart failure looks like and the difference. Like first you have heart failure, right? And then is it systolic, diastolic, or it could also be left and right, okay? So here's that if you want to look. Know the ejection fraction in size systolic and diastolic. Like know what's normal and what's not, okay? Diagnostics, again, BNP. Oops. And then see, these are all the other cardiac stuff, but your main baby is this one. You want to look at that one. Um, Lungs, this is like your triad. I think she already quizzed you on this. I'm not too sure. For sure, know your medications. Know what it looks like. Like, I don't remember if at the beginning you remember that simulation and she had you guys organize like the signs and symptoms or like possible side effects or whatever. This is all it, guys. So review it. For sure, beta blockers, ACE inhibitors, and the ARNIs, okay? For diuretics, know that it causes hypotension, not hyper. And honestly, I think that's it. Vasodilators, you want to monitor for orthostatic hypertension. Oh, the inotropes, so digoxin, okay? Because this is like the big one. You want to check the pulses, okay? And if it's below 60, like the heart rate, you want to hold it. Mhm. I remember, I don't know, was this on the first exam, guys? Like the yellow halos? Did she give you an example of like the patient had like the yellow halos? If not, maybe you'll see it. I don't know. Um, let's see. Digoxin, yes, see? I remember some stuff. Okay, digoxin, know this. Okay. Check apical pulse. See, I'm not lying to you guys. And then you want to monitor daily weights. Why? Because especially for heart, anytime there's like fluid retention, daily weight is gonna be like your key and like fastest indicator of like whether your patient's retaining water. So once I thought about it that way, it kind of just makes sense. Like, yeah, you want to make sure they're not retaining water, especially with heart failure. So nursing care always, okay? Obviously, always remember your diets. It's like a key, it's like a easy, ooh, sorry. It's like an easy test question, you know? What diet are you gonna say or like what are you gonna have them do? So, anyways. Um, I don't remember any of that. Go to the ED, go to the ER. I think she quizzed you. Pretty much included this on your exam already. I remember any of this stuff being on there. No, actually, I would review these just because these are complications of heart failure. Um, I would just review them, okay? So pulmonary fluids backing up into the lung. Patient is pretty much drowning in their like water, like okay, because it's backing up into the lungs, right? That makes sense. Pink frothy sputum is like the key word for this one. Cardiogenic shock. Obviously, there's lack of perfusion, so the heart's not pumping. Um, and then you're gonna see these symptoms. Who's texting me? Okay, but I don't really remember this being on there, but again, these are complications of heart failure, so just briefly review them. If you're good on that, then no worries. Asthma, okay, I remember there was a question about this. Let me see if I can know the three common like what it looks like, okay, manifestation. Oh yes, this right here. So know that the release of mediators, this, okay, those are triggers. Um, know your three main ones, like your common ones. These are triggers. I don't remember her going too crazy on the types of asthma. Again, like it's pretty like quick for the first one. For the old material. It's not a lot. Complications for this one. Understand that like status asthmaticus is a severe, she like even worded it in her lecture. It's a severe bronchospasm unresponsive to treatment and hypoxia. It leads to hypoxia, okay? But she gave me like, she gave, not me, she gave us like a specific wording. I think she mentioned like it was an acute respiratory stressor, something like that. So just remember that, okay, if you see it. Um, but it is a complication. This is what it's gonna look like. Make sure you were able to um, identify it, okay? What else? Pharmacology, yep. You better know that and that. Um, so she tells you like if she gives you a scenario if a person is having like an asthma attack, you need to know what you're gonna give, okay? If they already done the albuterol, like what's next? If they're already done, you know? Um, so kind of understand that. Long-acting and persistent asthma, again, you're gonna do like the Flovent, the Surbitant, all of that stuff. And then for this one, the xanthine derivatives, you're gonna make sure you monitor the blood levels, okay? Because again, what can kill your patient? This medication has a risk of toxicity, so it can look in like seizures or arrhythmias, okay? It can be really dangerous. So if this is what they're at risk for, of course they're gonna be contraindicated for patients with cardiac problems, okay? Pretty easy. Singulair, I remember this being on there. So review your asthma medications pretty much. Um, I don't remember any of this being on there. It's just pretty. Review it if you need to. Diagnostics, you're gonna form the asthma action plan. Okay. So, mm, so PE, I do remember this being on there, you guys. So if you're not familiar, um, understand the difference between a pulmonary embolism and what's the other one you guys go over? I think it's in PE. Hold on, sorry. Ooh, you guys, I'm sorry. Um, when we come through it, I'll let you guys know which one. But know the difference between PE. If anyone knows what I'm talking about, fill in. Okay, pulmonary embolism, so that like the dislodged or fragmented DVT, that is gonna clog up the pulmonary artery and it's gonna cause impaired gas exchange, okay? Um, so know what it is, one, obviously, because then that's gonna give you kind of like an idea of what to look for in the manifestations, okay? So dyspnea, pleuritic chest pain is the key symptom here, like, okay? And then, yeah, any of these like bolded, I would kind of pay attention to. Diagnostics is going to be the D dimer, okay? And the angiogram. That's the gold standard. This is the gold standard, but you're also going to do this one. So, ooh, um, for for medication, the heparin, um, whenever you do heparin, you're gonna pay attention to the PTT, okay? It's gonna be Q4 hours. If she says like Q6, Q3, whatever, no, like Q4. Unstable patient for this one, you're gonna give TPA. You'll see this medication later to at a place. So this is just gonna it's for high risk bleeding. You're gonna ask if they've had any recent surgery. That like if they've had any recent surgery, that just increases their risk for bleeding, so you don't want to give it, okay? Um, you have to start a Foley and NG2 prior to administration because they can bleed even from like the smallest puncture site. So before thrombolytics, TPA, you want to do these things, okay? So what else? Again, these are like your contraindications, and it makes sense, right, guys? Like if they're at risk for bleeding, like you don't give it to this. If they had a recent stroke, why? Because it can be a hemorrhagic stroke, and then that's gonna take your patient. That's gonna kill your patient. Active bleeding, same thing. Recent surgery, any of that. Nursing interventions. You want to have them bed rest, okay? Vital signs Q1 or Q2. Why? Because it's an invasive procedure, okay? Or I'm sorry, you want to avoid invasive procedures, but you want to give them bed rest, so that's why you do the vital signs Q1, Q2. Um, encourage ambulation and active passive leg. Oh my Lord, passive leg exercises. You want to prevent DVTs, and this is how you prevent them, and also like ambulation too. That helps for that. Dun, dun, dun. Okay, COPD. Any questions on that stuff? It's honestly, it's pretty like it's 3 questions. I have faith in you guys. Ooh, for this section though, for COPD, really, really know your signs and symptoms for emphysema and chronic bronchitis, okay? If you struggled with this in exam one, definitely review it because it looks like a drop, like you know what I mean? And you know her wording, pay attention to it because if she tells you the description for a blue boat bloater, but she says barrel chest, don't select that, okay? Because what's the barrel chest? That's the pink puffer. That's emphysema. So little things like that. I don't know if she did that on the exam for this one. I think first exam, right? Um, if she didn't, you may see something like that in the final, okay? So really go over your like the differences with COPD. And I would look at that one picture that she included in your PowerPoint with like the little like blue guy smoking or whatever cigarette. But yeah, mostly signs and symptoms for COPD, okay? Both chronic and emphysema. Mm, 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 mm. I'm scrolling over that because it's not red. You want to know your nursing interventions for COPD patients? Oh, really? Dang, she should have kept it. Or maybe that's where I remember it from. I don't know. But don't worry, you guys are gonna do good. I have full faith. Okay. Um, Controlled breathing. Okay, so just think of COPD. Okay, check on the patient, O2, any like you're gonna do vital signs, you're gonna work of breathing. You want to make sure they're breathing right. So breath sounds, labs, all that good stuff. Skin color, right? If they're blue, cyanotic, lack of oxygen, sputum and consistency. You're gonna give them O2, so cough, suctioning, breathing techniques. You want to get all that junk out. Oh, no way. Oh, I wish. Yeah, she has so many versions of the exam. It's crazy. Um, See? Uh, what else? Yeah, review your math. Sometimes she throws fractions in there. It's weird. Um, okay, yeah, and then drug therapy, know what you're gonna give. So bronchodilators, this makes sense, right? The, look at what COPD is. And then corticosteroids and mucolytics. Okay, you want to get all that gunk out. What else? Know what, I mean, this is kind of repetitive, honestly. Like, I wish I would have put this up there. If I do this thing next week, next quarter, I'm gonna fix this. Corticosteroids, it's just gonna reduce inflammation. So kind of look at the drug, the medication that you give for COPD patients and understand what it gives, okay? So for corticosteroids, at least for these three, sorry. Um, and then patient education, you should know this, like the breathing exercise, you want to tell them to like the pursed lip breathing, okay? You want to tell understand how to do it too. Like you inhale through your nose and then you exhale and push through your pursed lips. So, okay. Um, there's like a question like you had to like teach the patient how to do it. So, encourage water fluids if they don't have heart failure, right? Remember, like heart failure, you don't want to increase the fluid retention. This is going to break up the mucus and they're going to breathe better. Okay, dermatological cancers and precancerous lesions. Um, this should be easy peasy, you guys. Actinic, AK, what does this look like? Oh yeah, it's a precancerous lesion. It can become squamous cancer carcinoma. I don't remember what it's called. Sorry, guys. Rough, scaly patches. So know what it looks like, okay? Especially for these like you got this was exam two, right? For exam two, like you kind of see you guys know what her questions look like, right? It's a lot of like description, so you need to know your signs and symptoms, and then you need to know the treatment. So yeah, for this stuff, it's pretty easy. She doesn't go too crazy. I want to say this was exam two. Chiral surgery, what it is, causing blistering, what to look for. If they're receiving chiral surgery and the patient's like, oh, I have blisters. Yeah, see? So this stuff you guys know. So anything that's in red is kind of like what you might see again on the final. I will deny it if you say I said that. Okay, FU. She loves her medications. Okay, so understand FU, 5FU, sorry, 8K, and then education. Pretty much, honestly, for the medication, it's like if it has a severe side effect, you might want to know that. And then just the education over it. Okay, so this is like something like the patient may freak out about, right? So know that. For Aldara, same, the side effect. So I remember there was a lot of like side effect medications. Um, non for the honestly for cancer, this is gonna be your like safe pick, I think. Because the Mohs surgery, you want to remove like as much as it's cancer, you don't want it. So when in doubt, I guess you can do that. SK, don't quote me on that, guys. Go over it. Um, SSK, that's just like a duck, stuck on dark brown yellow papule. It's non-cancerous. I have one actually. I did go to the dermatologist like a couple years ago. Um, it just like it's brown and it's just like waxy. It's weird. It's gone now. It only comes back in the summer because of the sun. Melanoma, this is your most deadly is form of skin cancer. Again, know your A, B, C, D, E, F, G. Treatment, white excision. Oh, this is the one. I'm sorry. White excision. Your moss, I think that's the most expensive, no? Um, Wide excision, cut out as much cancer as possible. That's like the main goal. Okay. So that's that. Autoimmune skin disorder, psoriasis. Again, know the description. Um, know the topical stuff for it and like what you're gonna do, like when you're gonna give systemic and let me look at this. Hold on. Oh, now I know who you're gonna give it, like who you wouldn't give it to. So patient like who are pregnant or like liver function. If they don't have good liver function, you don't want to give it to them, okay? When you would give um when you would avoid systemic steroids, okay? Um, so obviously it's here, or why you would want to avoid them, I'm sorry. Topical steroids, I think mostly like the mechanism of action, if I remember correctly. Um, oh, always good to know if something's not curable, like I would remember that. Okay. Bacterial infection, this is easy peasy. Like we went over this last week. You also know this for OB, so I think it kind of merges nicely because if you know it for OB, you know it for her, honestly. For skin, you want to know what's contagious and the just the description. Um, yeah, honestly, like the description and if it's contagious, you want to pay attention to that, okay? Um, education on ha hand hygiene, soap, water, avoid scratching, all of that stuff, okay? So if it has a specific isolation like contact precautions, like you want to pay attention to that. Oh, I'm sorry, guys. A really bad acid reflux again. Folliculitis, that's just the hair follicles. I would also, I'm gonna go back to this. I'm backtracking, sorry. I would know what causes it. Like honestly, staph, staph, or strep. Okay. Don't make it hard. And then folliculitis, you guys kind of already seen this though for OB, so I don't think you guys will need help with this. Um, Folliculitis, obviously, if it's the hair follicles and like inflamed, you want to avoid the excessive sweating or like honestly, if you like go to the gym, you want to change out of your like stinky gym clothes. Keep the skin dry, avoid razors, all that stuff. That's like common sense. Oh, you guys have adult health first and then OB? Oh, did okay, never mind. We'll go over this then. It'll help you for OB. I thought it was OB first and then, but I think you guys are right. Um, but you guys have seen this for OB though, right? Hopefully. Similar. Some stuff. I don't think the skin stuff. Yeah. See, I'm not crazy. Who was it? Aid Daniel. Um, Not the skin stuff. I think for oh, you know what? You see this in peds. I'm sorry. My bad. You will see this again, guys. Um, and then the carbuncles. Okay. Sorry, I thought you guys saw it. Okay. In pedigo, you see this more in children. Okay. So, and you will go over this in peds. Folliculitis, the hair follicles, they're inflamed. Um, these lead to one another. Okay. So if you know these two, cool. These, easy peasy. For uncles, boils. Okay. Um, And this can just like the thing with this is they're painful nodules with central necrosis. Pay attention to that. And it's tr due to untreated folliculitis. So see how this can lead to this, and this is going to lead to that, and then eventually like it can lead to like worse things. Um, so kind of associate it like that, okay? For uncles, it's just boils. It's like, okay, there's pus inside, that's bad. Um, Warm compress initial, and then IND, and then dry dressing if it's not improving, okay? Antibiotics for whenever there's one in here, I think I'll go over it. It's this one. Carbuncles, it's a cluster of furuncles, okay? So it's more. Um, and it's a fistula formation with cellulitis, which can lead to sepsis, okay? That's why it's like really important to catch these. You want to assess for any infection, you want to see any hard to see places, all that good stuff. But honestly, for the skin stuff, I don't remember it being too like in debt. You just need to understand what it looks like and then if it's contagious and not contagious, okay? Necrotizing fest. Oh wait, did I skip one? Yes, I sure did. Cellulitis. This is gonna be like red, swollen, hot skin. That's what it looks like. It's gonna be warm to touch. This is a different cause, so group A, beta hemolytic, strep, or S. pneumoniae. What else? This is the one that you're gonna give aggressive antibiotics. Remember that, okay? You want to do a surgical debridement for deeper or if the infection is spreading. What else? Yeah, this is why they mark the borders, if you remember from your lecture, because you're trying to see if the infection is spreading. And if it's spreading, like risk for sepsis, which you could die from sepsis. So that's why they do those borders, okay? Necrotizing fasciitis. This is not contagious, okay? I think who was it that texted me about this? Yeah, it's not contagious, but you still want to do like I don't even think she disregard. Okay. It's not contagious though. It can spread rapidly on the patient. Okay, so that's why it's like this one's the flesh-eating disease because it's literally doing that. It's eating the skin. And then you signs and symptoms, fever, fatigue, you're gonna be in severe pain. Like think about it, right? Rapid progression, there's gonna be like crepitus, and then there may be like like open wound, okay? That's why it leads to the open wound, I'm sorry. Nursing intervention, pain assessment, exudate, redness, swelling. Um, you want, again, with this one, you want to draw the margins to monitor the spread. You're going to do dressing changes because they're going to most likely have an IND, and they'll probably have like a wound vac too. You're going to give them IV antibiotics. So anything in red here, you want to pay attention to. Of course, if you recognize it early, it's going to save their life, right? Makes sense. And you always want to reassess, especially for like all the like skin conditions, you want to reassess and see if like your treatment is working. Honestly, with everything. Infestation. So scabies, this is like the burrowing mites. So know what it looks like, okay? You're gonna look for anywhere in the little like crevices, like your finger webs, like genitalia, axillary wrist, any of those like hard to see areas, it's where you want to look because they burrow in there and like you're gonna see like a white streak, and that's literally the mite like in there. Oof. Severe itching, okay, especially at nighttime. This one is contagious, okay? Again, you want to pay attention. So if your patient comes in with like itchiness and you look and they like if you assess them and you look at their hand and they have that like, that little white line, like you already know like ooh, might be scabies. And then you ask if other family members, why? Because family members are also going to be treated. It's not on here. Did I? Yeah, I did. You want to know, and I believe I told this to like my other group, you want to make sure you educate them on part of the treatment is the education you're going to give to the patient and the family member and how to treat this. Okay, it's going to be the sulfur ointment. Okay, this is what's going to kill the mites. And everybody in that household is going to be treated, absolutely everybody, okay? Not just the patient, because it's so contagious. So they're going to shower before bed, okay? They're going to apply the medication everywhere, not just where they're itchy, right? Because they can literally burrow anywhere in the body. So everywhere, they're going to sleep with the medication, and it has to be like at least 8 hours. When they wake up, they're going to shower, they're gonna throw their stuff, their laundry, linens, everything, even what they were wearing in the washer, clothes, sheets, everything in hot water, and then they're gonna shower, and then they're gonna repeat this cycle again in 8 days. Why 8 days? Because that's how long it takes for the mites to like latch, like do their egg, like bury their eggs and like hatch and all of that. So that's why it's done in 8 days, in case you were wondering. But yes, everybody absolutely has to do this in the household. And again, it ties back to education on psychoprevention. Um, Chicken pox, I do remember like it's like a rose petal. Know the cause. It's a macule, and then it leads to papule, and then a vesicle, and then the crust stages. Okay, so understand when and so airborne isolation and contact if the lesions are open, like if they're not or not crusted over. Okay. Once they're crusted over, then they don't have to be an airborne and ice and contact. There is a vaccine for it, so that's good, like treatment and education. You want to avoid pregnant women without immunity. Okay. No aspirin because it increases the Ray's syndrome risk. So just know that one. Herpes, so shingles, herpes zoster, that's going to be like a painful stripe. So she gives you a scenario of like a stripe-like rash, like on the side or anything like that. You already think shingles, okay? Um, what else? Yeah, neck, flank, lower back. So your flank is your lower back. Shoulder, post-therapeutic neuro. Oh yeah, so a complication is like they can feel pain even without the rash. So know that one. And then antivirals is going to be your medication and pain control. So you're going to see gabapentin and Lyrica. Nursing interventions, contact isolation when the blisters are oozing. Okay, so know like if they're crusted or oozing, you want to know what kind of ISO you're going to put them in. And then keep rash dry and covered. And then skin breakdown. Um, it's there if you want to take a look at it, but I don't remember. Actually, no. Yes, for the skin breakdown and pressure injuries, it's an easy point, right? So really look like if she gives you a description of if the question asks for a stage in the response in the answer choices are like a few stages, like say she gives you stage 2, 3, and then one of these like unstageable or suspected DTI, don't select the unstageable or this. She's asking you for a stage. So it has to be one of these over here. If that does that make sense? Um, yeah, don't do that. Um, so if she tells you like stage one, it's non-blanchable, okay? So that means like it's red, okay? Um, Stage two, partial thickness loss. So I always think of this like a blister. Okay, so first it's just red. Okay, you might want to monitor that. That's like a warning sign, right? Stage two, I just remember blister, like a blister. And then stage three, like full thickness loss. So you're looking at like the fat and like slow. And then stage four, I'm like, ooh, we're seeing bone and muscle. That's bad, right? And then these three. So just kind of review your stages and just know like give yourself like an example, and if you can tell apart, then you're Gucci. Pancreas. Mm-hmm. I would know the functions like the exocrine and the endocrine function of the pancreas. What it does, right? So it helps with the exocrine, it helps with digestion, endocrine, regulate blood glucose. So, haha, you're gonna see this for diabetes, okay? Um, yep, but I don't really think this is just like review and then the red, pay attention. Acute pancreatitis. Oh yes. Let me look really quick. Yeah. This is new stuff, right? The pancreatitis. This is like final material, like newer, not exam two. Exam two. Okay. Okay. Perfect. So you can again, this is just three questions again. Pancreatitis, know which one is for alcohol and gallstones, okay? Know the signs and symptoms, like remember like the colon and the gray turners, the rebound tenderness. So it doesn't hurt when when you press, it hurts when you are lifting your hand up. Diagnostics, you want to take a look. You want to know your labs, okay? Uh, uh, I mentioned this to my like regular study groups. Um, she loves labs, and you will see a lot of labs on the final. So just a fair warning. They make for easy select auto apply. So really know your labs, especially the ones that like here are in red. Like I really kind of try to help you guys out. Complications, again, what's gonna kill your patient? Hypovolemic shock, right? That's due to that third spacing, hemorrhage, vomiting. Um, Pancreatic pseudosis, so know what that one is, and hypocalcemia. So nursing, treatment and nursing interventions. What are you gonna do with your pancreatitis patients? NPO, okay? You want to give this, and I mentioned it a couple times, not today, but prior study sessions. With the bowel stuff, a lot of it is like bowel rest, right? If they're having bowel issues, you don't want to aggravate it, so you want to like encourage bowel rest. So what's the easiest thing? NPO, NG2. And that decreases pancreas stimulation. You want to give IV fluids, LR. I don't think she goes too crazy about it, but the difference between normal saline and LR has electrolytes in it, okay? So for pancreatitis patient, any bowel stuff, it's easy to be like dehydrated, so it makes sense that you would give an LR to them, okay? And again, here it is, electrolyte replacement. And then you can give calcium gluconate. So albumin, al plasma expanders, because of that third spacing, you want to, albumin is a protein, it's going to hold in water. So it doesn't shift into that third spacing. Vasopressors, blood replenishment, pain control. So that can either be a patient-controlled pump, IV opioids, okay? Because remember, they're in like big pain. Oh, I said this to my other two last week's. Um, really know your diets, especially for like the newer stuff, the bowel stuff, like any of the newer content. Understand like your diet for each disease process, okay? So for pancreatitis, you're gonna oh, this, I remember this. This is like for sure on there. Wait, this is exams too, so you guys know this. Um, was this on there, guys? Anyone? Um, yeah, this was I think she asked a question about enteral. If maybe, I don't know. Daily weights, all of this, anything in red, guys. Pay attention to that, okay? Chronic pancreatitis, same thing, it's just chronic, persistent, you know. The cause is she wants you to focus on is alcohol for chronic. Cyria, so you're gonna see that like what does the stool look like? Stone colored. And that they're gonna have malabsorption, okay? And then you kind of think like, okay, if they're not absorbing their nutrients, what is that gonna like relay that like manifestations on the patient? Weight loss, they're gonna have impaired glucose regulation, right? They can't. they're already having issues. And then diagnostics, increase LFT. So again, you want to know your diagnostics. Yes, exactly. Again, think in that, and again, Daniel, good. Yes, exactly. Because what's one of the functions of the pancreas, right? And that's why I put this up there just to remind you guys, like, okay, what does the pancreas do? What are the functions it has, you know? Okay. Thyroid stuff. I think it's pretty much the same thing, honestly, as exam two. So if you did well in exam two with adrenal section, it shouldn't be bad. If you didn't, I would definitely review because you'll see a question possibly. Again, nothing certain that I say. Um, you might have the little arrow things again if you haven't seen them, okay? Um, and it could be like, oh, hyperthyroid, and like she'll give you like the lab values THS and then the T3 is elevated and you have to kind of know what it's going to look like for each disease, okay? For adrenal and yeah. Hyperthyroid, this is the Tigger, right? Everything's up, okay? Hyper, and then you're gonna the way I told your peers is like exophthalmos. So that's like the protruding eyes. So I just think of it as like grape eyes, the G, and then grapes, okay? And then last hormone controls the first hormone, so obvious. And then treatment is PTU for hyperthyroid. Okay, so again, this is super condensed compared to like the other notes, right? Um, Radioactive iodine. Understand that the RAIU, it destroys overactive thyroid cells, yes, but if you give too much, it's gonna kill, it can kill too much. So you want to avoid it in people with hyperthyroid, okay? You want to avoid, my notes did not make sense. Oh, yes. You want to avoid giving it to people with hyperthyroid because it'll make them go like turn them into hypo, okay? It'll tank them. It'll do the opposite. Beta blockers, this is the one you want to give right away. Okay. Post-op, this is important, right? If they had surgery and any like surgery like for like throat, anything like that, laryngeal edema, that's like if they have any voice changes, anything, or they're like constantly swallowing, um, let the provider know right away. That means that there's complications and always have an airway set up at the bedside. So, and then know this thyroid storm again, what's going to kill your patient? This will definitely kill them. Know what that looks like, your signs and symptoms, and then treatment, okay? Hypothyroid, again, just know your signs and symptoms, know your treatment for it, and then your signs and symptoms here that are in red. That'll be helpful. And then honestly, this is not even that important. The goiter, just know that it's a compository mechanism for like either hyper or hypo. It can happen in both. Okay. And then adrenal cortex. Honestly, guys, if you knew this for exam two, you are good. It's not going to be complicated. It's easy. Um, if you had trouble, then I would go back and review, okay? And you can ask your classmates for notes if you need them. Um, that I don't mind. Yeah, so again, Addison's is just little Addie. She's down bad on all three. No sex, no assault, no sugar, okay? Uh, review your signs and symptoms and your labs, okay? So they're kind of like merged together here. But yeah. And then what tests will you do for each? Again. Um, yeah, so that's just the primary, secondary. You guys know that. Pituitary, yeah. Yeah, that's easy peasy, guys. You guys already went over this. I would know your treatment though. Again, anytime you're giving steroids, just remember to taper off of them. You never stop them abruptly. Cushing's, that's too much sugar, right? Again, think like diabetes. So hyperglycemia, muscle wasting, thin extremity, they're gonna bruise easily, delayed wound healing, all that jazz. You know your diagnostics for it, okay? And then for treatment, I would know this one because I remember that comes up. Um, oh yeah, for if they're having a surgery for it, you want to give them hydrocortisone, continuous IV because it's going to prevent bleeding or Addisonian crisis, which this can, right? That's a complication. Hyperaldosteronism, that's too much salt. Just know, easy peasy. If it's the kidney, it's renin, okay? Like the renin's gonna be the problem. Um, so here, the renin's gonna be up if it's low, and then you already know that your salt's gonna be high. So yeah, just pay attention to the renin. If the renin is high, kidneys, okay? Here's a simplified version if you need it. Treatment, it's spironolactone. It's just the potassium sparing diuretic. And then congenital hyperplasia, she doesn't, I don't, I don't remember that being on there too much, honestly. Um, I do remember a lot of questions on this though, so if you don't know it, I would go over it because I wasn't expecting that many questions on pheochromocytoma. It's just an adrenal tumor, excessive fight or flight symptoms. So again, thiramine rich. Again with the diet, guys. Know what it is, okay, and know what to avoid. You're gonna see your triad of signs and symptoms. So here they are. And then treatment, you're gonna do the well, let's just say diagnostic test, but you're gonna do the clonidine suppression test, and then if it's normal, the clonidine seen as suppressant, it's gonna suppress. So you do this test, and then you're gonna. This is what you're gonna do, okay? For fetal carcinoma, there's gonna be no suppression though, okay? So the catecholamines are gonna just stay high. So that's how you diagnose this. Okay. Alto brow. This is like the newer stuff, okay? This is gonna be where like all your money's gonna be for. Bowel obstruction, know the types, so know what that looks like. Okay. Well, first of all, know that it's like contents and all the fluid, whatever. Know what it is, okay? Which it's a obstruction. Don't make it complicated. Know that there's two types, mechanical and functional. So that's like the paralytic. It cannot propel forward, okay? Mechanical, there's just like something causing pressure on the intestinal wall. It can be partial or complete, and then small or large intestine involvement determines severity. So good to know. Know you what this looks like. Your typical presentations. Um, I always think like, okay, if you're not having any bowel movements or there's an obstruction, it's not coming out the end, it's gonna come back up forward, okay? Um, Typical presentations, this is like general, okay? Abdominal pain, obviously it's obstructed, it's gonna be painful. You're not gonna want to eat, you're obviously gonna be constipated, vomiting, right? And then you're not gonna be able to poop or fart. And then you might see abdominal swelling, so distension. Again, all of this should make sense, right? If there's a bowel obstruction, like think of what's gonna happen. Common causes are hernias, adhesion. I think she wants you to kind of. I remember there was like a question about this. It's like I always think of a telescope for this one because it kind of folds into like it slips into another, and I think of like the telescope, it's slipping in. And it's narrowing the lumen, okay, which that leads to bowel obstruction. It's just more common in children. I don't really think she. Actually, I would review the causes, yes. But I think this one was on there. Mm, 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 mm. Here is a comparison of both. Honestly, I'm just gonna go pretty quickly. I just saw the time and I know you guys are tired. Unless you guys have specific questions or anything, but honestly, anything that's in red, you guys should really review. Especially for the newer material. Um, really understand each disease process, okay? Um, Here's a comparison, so easy, like just whatever works for you to remember. Small bowel versus large bowel, one sudden, one slow. Like look at the signs and symptoms, like the pain, the vomiting, all of that stuff, okay? If there's not gonna be any hype, if there's no gonna, uh, if there's no bowel sounds, like I would start thinking like large bowel obstruction. What the heck? Um, they're both like if they're both have the same symptom, like I would just look at what's different because that's gonna tell them apart, right? Because a lot of the bowel stuff, it kind of sounds the same, honestly. Um, so absolute constipation, that makes sense. Oh, for small bowel, your small bowel is closer to like your stomach and your stomach is closer to your mouth, right? So you're gonna see a lot, that's where you're gonna think, oh, well, it hasn't made it to the large bowel and it's gonna come back up because obstruction's there. That's why you're gonna see that bilious like bile um, versus in large bowel, you're gonna see like the poop, like the fecal vomit, okay? And that'll tell you like, ooh, it's traveled a far, so it's gonna be large. So look at that. Here it's crampy, here it's colicky. Yeah, so remember there's still an obstruction. So whether it's in the large or small, it's still like it's an obstruction in the bowel system. So because of that, it's gonna cause pain, and then you're gonna lose loss of appetite too. It's weird how the body works, dude. But yeah, if you're think of like whenever you're constipated, like you don't want to keep eating, right? So honestly, a bowel obstruction like it causes constipation too. Um, yeah, no worries. So yeah, so this one's like a common symptom for both. Here, if you're vomiting, you're losing a lot of fluid, so think like dehydration, right? And then here, if it were diarrhea, absolutely. But large bowel, like you're not having any bowel movements, you're constipated, so you're not really gonna see it, right? So just kind of work through that to help you understand each. And then obviously the hypoactive, like or absent sometimes, that's gonna be like, ooh, large bowel stuff. High pitch, mm, that is gonna be a small bowel, okay? All right, so again, like really understand the signs and symptoms for each. These notes are really condensed. So just go over like your notes and then touch base, like look back at this, okay? Um, Treatment, oh, diagnostic, know your diagnostics, okay? Um, History, signs and symptoms, imaging, mm, chem panel, honestly, maybe like history, right? And symptoms, because that's gonna tell them apart. And then you obviously you're gonna do a X-ray or a CT or MRI. This might be for like small bowel, right? Because you're losing the electrolytes because you're vomiting. Let's see. Conservative management or treatment, you definitely want to know your treatment for this, okay? NG2, you want to give your bowel rest and you want to have them NPO. You don't want to stimulate the bowel. Uh, Complications. It can lead to strangulation or perforation. This is gonna be like what's gonna kill my patient, okay? Um, it can perforate and then peritonitis and then sepsis, okay? So that is gonna kill your patient. Obviously strangulation too, because this can like lead to it perforating, but yeah, look at what's gonna kill your patient. Complications of surgical interventions, for sure no dumping syndrome, which is what you want to monitor for. Um, this is like when the patient has surgery and like they eat and they can eat um in their body, like the small intestine isn't properly digesting it and it's literally just going through them. Like, okay, so that's just what I think of it. So if it tells you anything like that, it's dumping syndrome. AG2 decompression. This is you're gonna use this until the bowel function resumes, or the symptoms resolve. You can do intermittent suction unless the patient has an air vent, okay? And you want to do this, why? Because it prevents mucosal damage. You want to access suction and placement at the start and end of each shift. Um, the gold standard for this is like the initial, when you first insert the NG tube, it's gonna be what? Anybody know? I just want to make sure you guys are awake. X-ray, yeah. You guys better know this. I went over it last week. Daniel, not the new people. Okay. Document I's and O's. So you want to make sure you document the amount and consistency and color, okay? Um, Again, if like say they're having a small bowel obstruction and they're still throwing up that like green bile or anything like that, like ooh, okay, our treatment's not working. You want to monitor for improvement too. Are they still distended? Are the bowel sounds, like if they had a large bowel obstruction, are you able to listen to bowel sounds now? And you want to make sure your patient is comfortable. I don't know if that's possible. Okay, IBS. IBS and IBD, when I something that helped me like distinguish them is irritable bowel syndrome is symptoms, right? It has the S at the end, right? So it's all symptomatic, honestly. And it's due to a change in motility. Okay. Oh, here it is. And it can be for a couple of reasons: hormonal dysregulation and infection or irritation. Okay. So easy thing to think of is like someone eats food that's like irritates their stomach, um, that changes their motility, that can be IBS. Okay. There is no inflammation in IBS. Cute. Like that's a key thing to remember because in IBD there is inflammation. Symptoms, they're going to be constipated, diarrhea, and then there's different types of IBD. There's IBSC for constipation, IBSD for diarrhea, and then IBSM for mix. I don't think she doesn't ask anything about this. And then pain, bloating, and abdominal distension. See how all these bowel things? Which one? Oh, she's funny. It's easy too. Oh man. Yeah, no, she doesn't care about that. She just let you guys know that there's different types, but no, she doesn't quiz you on it. Not that I remember at least. But it's there if you need it. Diagnostic findings, assessment of symptoms. You wanna again, this is a like a I call it the symptom, like it's not even a disease, I guess. I don't know, syndrome. Um, they're gonna have reoccurring abdominal pain for more than 3 days per month for the past 3 months. This is gonna be key, okay? Um, really know this one. Pain, it improves after bowel movement, and then again, it's a change in motility, like thing, right? So they're gonna tell you there's a frequency in changes in frequency and consistency of their stool. Um, so this is kind of like, okay, your patient comes in, this is like your initial like intake, right? You're asking them for the signs and symptoms. If they say these things, it's like, ooh, red flag, right? Um, then you're gonna do this. You're gonna do the barium enema or the colonoscopy. And then so the barium enema, I think it like highlights it or something like that. And then stool studies or x-rays to rule out other causes, okay? So they might want to look at their stool to see what's going on there. Treatment, obviously it's based on symptoms, and surprise, surprise, if something's irritating your stomach, take them out of your diet. Yes, that's what it is. The barium enema. Oh wait, hold on. What are my other notes? I'll go back. I'll go back and check, Sean. And then okay, yeah, but eliminate irritating foods. And then again, with the diet for this new material, really know it, okay, guys? So know if it's high fat, low fat. Very rarely do diseases have high fat, okay? Just throwing it out there. Um, Especially for stuff you learned in tomorrow's class. So high fiber, again, you want to promote like a healthy bowel, maintain hydration, and then exercise. So it's going to improve your bowel movement, reduce stress, because again, like stress can also cause this. And then, well, exercise because it reduces stress and anxiety, and then you want to do whatever else reduces your stress. I don't know. Medications. She gave you a list. I would focus on the ones in red. I think probiotics kind of like, yeah, you need healthy stuff, right? Yeah, it's up here though. Hormone dysregulation. I got you. Um, Honestly, I don't even think she's gonna like she might give you like a patient scenario and she'll say like the patient was having like recurrent abdominal pain for like 5 months or like 5 days a month for the past like 4 months or something like that. So really understand like this and what it is, okay? Um, and then for medications, antidiarrheals, right? Because you want to loosen up the stools if they have diarrhea, okay? Um, this is kind of where it helps to know like the IBSD, like the different types, and then because then you'll know who to give it to and who not to. But I mean, if they're having diarrhea or not having diarrhea, like you should know. You're not gonna give them something that causes more diarrhea. Form for bulk forming laxatives. Okay, so if they're constipated, that makes sense, right? You want to give them something to help them pass stool. Antidepressants. Why? This one was actually interesting to me. It's going to reduce pain sensitivity and stress related symptoms. So again, this is like, remember, one of the like triggers could be stress. Okay. And obviously they're going to be in pain. So that helps for that. So this is good for both. And then again, anticholinergics, it's just going to decrease the spasms because it's a change in motility. Okay. And like it's a spastic colon. That's what she said. And then nursing management, you want to provide education, support again. Like I cannot stress enough, you guys know the diet, okay? If you guys miss any diet questions, I'm gonna be so upset with you guys. I'm just kidding, I wouldn't be upset. Just kidding. Reinforce the treatment plan and like if the triggers food that they're eating, you want to help you want to identify it, right? So have them keep a food diary. See what triggers them. That's it for that one, okay? Any questions? I'll like any questions on this one? Because this is new material, so and these are like super condensed notes. Okay. Okay, inflammatory bowel disease. See what I mean? IBD. Don't confuse these two, okay? IBD. If there's a D at the end, you know it's a disease, and you know the I is for inflammation, okay? So there's inflammation going on, and there's two types. So you have Crohn's and you have ulcerative colitis. Again, like the COPD, know your signs and symptoms. There was a similar question to that type of question, okay? Um, you want to know that what Crohn's is and think of the C in Crohn's as cobblestone appearances, okay? There's formations of fistula, fissures, and abscesses, And Crohn's can happen in any part of the GI. Homie goes everywhere, okay? Symptoms, look at like the signs and symptoms, okay? There, this one's gonna be like the fatty stool, the fluid loss because they're gonna have diarrhea, uh, crampy abdominal pain. Pain, this is super important. Pain after meals, and then they're gonna have malabsorption again. And that kind of just goes with like bowel stuff, you know? If there's bowel issues, most likely there's gonna be like some kind of malabsorption of stuff. Um, so what that looks like in your patient, weight loss, malnutrition, anemia, and the malnutrition is due to the malabsorption, okay? Not because they're not eating. And then yeah, everything in red, honestly, yeah, I would know. I know it looks like a lot, but you have to know it. And then UC, okay? UC is the ulcerations. It's literally in the name, guys. Don't miss it, okay? And so for this one, I would look at this one's a multiple ulcerations, continuous pattern. There may be bleeding, and that's because think of it like the ulcer, right? It's inflamed all the time and it's shedding the colonic epithelium. So that's like that's where the bleeding is coming from. And honestly, I'm straight up. I just remembered ulcer bleeding. See, I even wrote it here. Oh, symptoms. This is where you're gonna see the bloody mucus, and again, that should trigger something, right? Bloody mucus, like ooh, ulcer, right? This one's gonna be 6 or more stools a day. She will give you something like this, okay? Stools like 6 times a day. And actually, didn't you guys do like bowel questions? Like a group thing? I think your bowel questions come from there. She may have switched it. I don't know. But yeah, she like look over those and she will pick questions from there, okay? So those are like easy points, right? Because you literally have the questions. She might switch like there was like a group assignment and you guys had to do like questions. Mm-hmm. Yeah. So go over those. And I think she did it for skin too. Um, yeah, I would go over those. Like really like understand the questions there because those are like free points, guys. Uh, she might switch like a little thing here and there. So again, it's always nice to know the signs and symptoms because if she switched something, like you know, right? Okay. I am trying to go like super fast. It's so late. Sorry, guys. Okay. Signs and symptoms, the ones in red are kind of like the ones that stand out to me. If something else stands up to you, then do you and add it on, you know? But I always think of the L too. So ulcer, right? There's ulcers. And then the L for left lower quadrant pain. That's how I remember this, right? I don't make things hard for myself. Like I need to be like it's a lot of information, right? Think of ways that you will remember things, right? And then this one, the Crohn's, it's not on here, but it's like left lower, like right lower quadrant, I believe. Something with the R. And it's like the R's in there. Um, and then signs and symptoms, yes, they're here. The everything in red, guys, honestly. Okay. Because these are kind of like they could go with both, honestly. And then IBD complications, what's gonna kill your patient? These two are like bad, okay? These are bad too, but like you can catch those and you can fix them, but like this is gonna be like surgery status. Your patient's dying, okay? Toxic megacolon, I think is the one that she like really goes into. Um, the inflammation's gotten so bad it's gonna extend into the muscle and then it just stops. And then it's gonna the colon distends and then again risk for perforation. You guys know what that does already. These are your signs and symptoms, and then your treatment, okay? NG suction to decompress. You're gonna do these treatments. If your patient does not respond to these treatments, like after 24 to 72 hours, surgery, okay? Because they're at risk for peritonitis, and then if that happens, risk for sepsis, and then potentially die. Diagnostics, again, I'm sorry, you guys, you do have to know your diagnostic stuff for this. Um, don't make it complicated. Your CBC, right? Because what can go on? Ulcers, the bleeding, so it makes sense that you're gonna look at your hemoglobin, your hematocrit, and then your white blood cells. Why? Because there's inflammation. Your ESR and your CR, these are inflammation markers, and hello, it's in the name. I like IBD. There's inflammation. So don't make it hard for you guys, okay? Um, Imaging, it's gonna be CT. They can also do a occult blood, and then there be fatty stools, especially in UC. And then the barium study again for the oh yes. For Crohn's, it's the barium study, and that is like the dye that moves slow. Okay. Um, this one I'm not even gonna try and pronounce that. That one's for UC. I'll write it in here for you guys. It's not in here, sorry. So if she asks anything about that, like those are like specific for that disease process. Treatment goals are here. Pretty much you want to relieve pain. These people are in pain. You want to prevent fluid deficit because dehydration, it can create a whole other kind of problem. And then maintain optimal nutrition weight. So remember I said know your diet, because if you're trying to maintain optimal nutrition and weight, she's gonna want you to know what kind of diet. Um, Nursing management, monitor I's and O's. You want to monitor labs. I mean, all this kind of makes sense, right? And then, oh yes, provide easy access to bathroom or commode. Remember, these patients have like diarrhea, so you don't want to have them like diarrhea all over the room. Um, Bed rest, of course, to reduce the peristalsis, and then administer medication. So you want to help them relax their bowel, and sometimes eating is painful, which going back to uh who asked that question? Ernie. Um that's remember, like they're having low appetite, they're in pain, right? So you want to decrease that. So anticholinergics 30 minutes before meals because it helps them relax their bowel. And then you want to monitor for bleeding, EKG changes, level of consciousness, and then abdominal pain. So a lot of pain stuff with these folks. Nutrition, I cannot emphasize enough. Know your diet. Know what to avoid. Okay. Um, what else was on here? Oh, chocolate is I guess, I don't know. I did not know that was a thyramine choco. Oh my God, you guys, I'm done. Also, sorry for stressing you guys out yesterday. That was my bad. I don't know what day it is anymore. Oral supplements and electrolyte replacement. You're gonna do IV therapy if they're obviously dehydrated. Um, TPN, understand TPN, okay? You're gonna do the central line. It's a 2RN check because it is a chip med. And then you do not want to stop abruptly, okay? If you do this, they're at risk for hypoglycemia. So because it's a high sugar content, right? If say your infusion stops and they haven't brought up the new replacement bag, you can give dextrose in with water to maintain them. And again, remember it's like 20, it's like high glucose, like it has a lot of sugar. So you just never stop it abruptly. Um, and then you want to monitor for fluid electrolyte, glucose levels. Obviously, it's look at how much sugar it has, right? Make it make sense to you guys. IVs, site for infection. It's a central line. You wouldn't want to get an infection there, right? And then change the tubing every 24 hours. I would know this for the ATI portion of it. I have a document for you guys if you guys didn't attend last week. But yeah, know when you're gonna change the what the time frame for changing the bags. So here it is. And then you want to again taper off. And if you you don't need to know that, but if she were to have it in there, like, oh my God, you don't stop it. You just give them dextrose and water. Okay. Pharmacology, drug of choice is aminosalicylates, sulfa or non-sulfa. That's the main one you want to focus on. Um, to prevent relapse, you want to do like immunomodulators or biologic therapies. So that's Humira or like, I want to say she focuses on this one, honestly, methotrexate. And then, whoa, I don't know what's going on here. Yeah, just know there's different routes, but honestly, just know the medications that you might give and which was your drug of choice. Aminosalicylates, this one is used for mild to moderate IBD. And the thing you want to know about this is it takes a while to kick in, okay? So it takes 2 to 4 weeks, and it's for long-term maintenance. You want to monitor renal and CBC, but mostly it's renal. You want to make sure their renal's working, okay? And then sulfa, non-sulfa, mm, I think she gives you aminosalicylates, honestly. Don't even worry. I think she gives you both. She's nice. And then check for sulfa allergy, obviously. You don't want to give them something that they're allergic to. Corticosteroids, this is going to be for immediate relief. So I kind of like know which one you give for which type, okay? And then, so short term, long term is what I'm saying. And then side effects, you want to know these side effects right here that are in red. So side effect with the corticosteroid is osteoporosis. What is going on here? Okay. And then, so yeah, if they're at risk for this, you might want to monitor their vitamin D, their bone density, and blood glucose. Immunosuppressants, this is what you want to focus on. It's used for long therapy. So know if it's for short, mild, or long term. Yeah, mild to moderate or long term, okay? What kind of therapy are you going to give them? Therapy as a medication. And then this one also takes months to work, and then this one decreases steroid use. So use steroids sparingly. And then again, this little baby comes up, so you might want to take attention. Oh, this one is a teratogenic one, so you wouldn't give it to like, or you would want to use contraceptives, oral contraceptives, okay? Um, and then this one may cause bone marrow suppression and thrombocytopenia. You want to avoid crowds and infections. Anyone that's sick, you want to stay away from, okay? Biologic therapy, you want to look at the anti-TNF therapy, and then this one's used for again for long term. You want to screen for this one specifically, you want to screen for TB and hepatitis, you want to report infections, signs and symptoms of infection to the MD, and then you want to let your patient know this one reduces the medication effectiveness, so don't smoke. Surgical, I don't really remember anything like going too crazy on that. Yeah, no. This is the one that I would focus on, if anything, is the internal pouch. Um, the content ileostomy. So ileostomy, guys, don't make it hard. And I would focus on these right here, okay? Anything that's in red kind of stands out. Um, Post-op, of course. Oh, yes. The stoma, you guys, the stoma is huge. So if anything, for sure, post-op. This you kind of do want to like know the like what it is, but the post-op, right? If they have a stoma, what should it look like? The output, like their fecal output should be a continuous liquid. It should never be clumpy or formed or anything. It's liquid, okay? Um, it should be beefy red, and if it's black or dusty, that's an indication that there's poor circulation, and that is not good. Not good, okay? Patient might have to go well, actually, they will probably have surgery. Um, the ilio reservoir, that catheter for 2 to 3 weeks, and then Monitor fluids and electrolyte imbalances, so high risk from liquid stool, okay? Um, yeah, that's simply because why did I write that? Oh, sorry, sometimes my notes don't make sense. So you monitor for this because they're at high risk due to the liquid stool. They're going to be strict eyes and nose, IV fluids, and electrolytes, and then the NPL with NG until the bowel function returns. So again, if you see this, like this is always until things start going back to normal or improve. And then of course you want to monitor for any obstructions. This is just a quick little summary for both if you are crunched on time and you want to just look at the quick spark notes. Oh my gosh, you guys, I'm tired. Oh God. Okay. I'm not gonna talk a lot. I'm just gonna honestly everything that's in red is kind of what stands out, okay? Where did we leave off? Oh my goodness. It's a lot of red, you guys, but don't freak out, okay? Don't freak out. You guys are gonna be good. All right, 10 questions. Let's go. Um, for gallbladder, oh, this needed to be here. Oh, okay. The function, it just emulsifies fat. I would honestly know your 7 Fs for this one. Fat, fair, fat intolerance, female, fertile, uh, flatulent, just farts a lot, and 40. Okay, anybody over 40. Um, gallstone formation, know what it's made of, so you understand it. Okay, for all these, like honestly, I wasn't expecting there to be so many questions on this, but there was. So know the differences, okay? Cholecystitis, itis means inflammation, so you know there's inflammation in the chole, which is gallbladder. So it can be acute or chronic. Understand your signs and symptoms. So Murphy sign, right upper quadrant. Pain, especially after fatty meals. Key word here, after fatty meals. So if she gives you a scenario that the patient just ate a greasy cheeseburger, anything like that, and then pain right after it, you're gonna think cholecystitis, okay? This is the treatment for it. Cholelithiasis, lith means stones, so it's telling you in the name, right? It's in the name. There's stones in the gallbladder, okay? So, dun, dun, dun. You don't need to know this. You already know that. And then where signs and symptoms, right upper quadrant, and it's going to be sharp, dual sharp cramping or recurrent. And this one's going to radiate. Pay attention to where it radiates, okay? Um, this one's going to radiate to the right shoulder blade. So keep that in mind. Worsened by greasy fatty foods. Yes, we know that. Jaundice, this is different, right? So you might want to pay attention to that. Again, look at the differences between these, okay? And then the treatment, honestly, some of the treatments are kind of the same for these. So, choledocholitis, it's in red because that means bile duct. So it's literally in the name, right? And then we know that lith means stone, so gallstones in the bile duct. The one with the D is the duct. Easy peasy lemon squeezy. Um, Symptoms, right upper quadrant, mid upper abdominal pain, and then this one radiates to the shoulder, okay? One to the shoulder blade or the back, most likely back. This one to the shoulder, okay? One is shoulder and back. This one is straight up shoulder. Look at the pain. It's sharp, cramping, and dual. And then this one is kind of the same, but it's reoccurrent, okay? This one is too. So that's why you gotta know like these little small details. Triggered by greasy foods within minutes. Yes, we know this. Nausea, vomiting. Again, jaundice because where are you in the gallstone? Okay, or in the oh my gosh. I'm sorry, guys. I'm so tired. And you're in the gallbladder. And then imaging. I think for this one, it's the Haida. That's the gold standard. Anything that she says gold standard, ooh, gold standard, you want to know, okay? ECRP, yes, you can do that. I would just know this one, honestly. And then medications, yeah, you do want to know the medication. I think it's she literally gives it to you or Urtisol. And oh, the shockwave therapy, they just break up the little stones, okay, with the little lasers. I think it's lasers or shock. Shock waves is the proper name. Uh, yes, Sean, yes. Oh, I'm sorry. Ask. I was looking for you net last week. You didn't come to study group, dude. Um, I don't mean to call you out, I'm joking. Yeah, this is like literally here. Um, do understand. It's okay. Do you understand he brought up a good point. The biliary tree, she really wants you guys to know it. Ugh, it's dumb. Um, just look it up. Like look at the biliary tree and it just branches off, right? So if anything goes wrong, like But this is pretty much like it. Um, she doesn't quiz you on it. She just wants you to understand because it helps understand the problems. Um, what else? Where were we? Okay. The shockwave and then the ECRP with the dormer basket. It's literally like the little basket and it scoops up the stones. Post-op care, you want to encourage ambulation and deep breathing because it's gonna decrease that gas pain. Oh, if you need to leave, you're free to leave at any time. Just write your name in the chat, please, okay? Thank you. Surgical, laparoscopy, post-op. So you want to like this is the intervention and this is what it is, okay? So look at that, not just like the title. And then Sean, if you need the ATI stuff, there's people who came to the like last week and they have it if you need to go. That's fine. Nursing actions, pain management, anything that's in red, okay? Honestly, are you guys okay if I just like scroll through it? Anything that's in red, just pay attention to. Otherwise, I'm just like reading off of it. Yes, perfect. Awesome. See, I like that way you guys roll. All right. Do you guys have any questions though? Because if you guys have questions, I do want to answer them. But I'm tired, you're tired. And also, really quickly, while you guys are debating, I know you guys had ATI, right? I have that link for you guys. If you guys need to retake ATI really can make or break your grade. Watch these videos. I know they're long, I know, but you know what? If they're gonna help your grade for diagnostics, um, how did I remember them? I'm trying to think. Honestly, I just have like, okay, if there's stones, you know that you're gonna look at the signs and symptoms. Oh yeah, don't worry, don't worry. Yes. Two people asked the same question, yes. Um, for the bowel stuff, honestly, it just depends like where is the gallstone at? Um, and a lot of it is like, okay, this one's gonna be gold standard for gallbladder disease, so she kind of tells you, right? Um, and then for these, like ECRP with Doma basket, that tells me there's a little basket at the end. They're scooping up the stones. This one's a shockwave. So you want to get rid of the stones, so you're shocking them, or they can do dissolvers. So this is just aerosol. That's what it does. It's gonna dissolve the little stones. Um, Really important though, some of these medications, like they'll remove like they'll prevent, but they don't remove some of the ones that are already there. Um, okay, I'm getting a lot of responses. I sent out the ATI stuff. It's level up RN. I just took ATI this week for peds, and that was hard, but I passed. So thank the Lord. Um, you guys, this stuff, this level up RN girl, I love her. She's my girl. She, they're time consuming, but just put in the effort. If you really need ATI to like give you a boost for the final, I would make time for them, honestly. I gave you guys both fundamentals and OB, okay? So that's in the chat. And then while you guys are, let me go up. Honestly, the old material, I would really know all your bowel stuff, know your signs and symptoms because that's gonna help you distinguish between them. Your diets, there was so yeah, of course. Um, I'll let you guys record right now, actually while I'm yapping, because I have ATI stuff for you guys too. Um, I'm just gonna scroll, so I mean diabetes. Um, Honestly, because of the ATI, the diabetes is kind of like it can add up. If you struggled with it for the lax exam, I would review it. Because again, like ATI gives you so much questions. Oh, sorry. You let me know when you're ready. Um, so you have diabetes, you have like a total of like almost 18 questions. I did. Did I go over diabetes? Oh yeah. I went over when did I go over diabetes? Sorry guys, like I went over like the newer stuff each week and last week was my last week going in depth over like everything. These notes are super condensed. So if you know anyone that has attended like if you need more information on it, from exam two material and final stuff, I would reach out to them to see if they can maybe share notes or something. But I can't send it to you guys, sorry. Um, but right now you guys have free will. You guys can, you know, utilize free will right now. But yeah, Daniel, I did go over diabetes last week, 2 weeks ago, maybe. Where were you at? Not at study group. I'm just kidding. Um, I can bring up the document. I won't be mean. But yes, diabetes is on here. It's just really condensed. This is all old stuff. Honestly, it's like it's 3 questions. If you're struggling on time, I would honestly just review what you did really, really bad because it's a sign that you may not understand it. And that way you don't miss it on the final, right? Because it's like 3 questions. But if you don't have time, focus on the newer content because it's a lot, especially the bowel stuff. It all kind of sounds the same, and there's just key little different things that distinguish like what it is. Um, know your difference between UC and Crohn's. Um, your signs and symptoms. Small bowel, large bowel. Um, don't get mixed up. Going back to like old material for heart failure. Make sure you know your right versus left. Um, what else is on there? I think your female repro is okay. Um, there was a lot of questions too on like, oh, AKI, yes. Wait, are you asking about AKI or for AKI know your values and there's one value that yeah, AKI. Um that shows up like are you gonna be hypo or hypernatremic? Um and know your signs and symptoms and your phases, like your recovery phases, okay? Um STI stuff, if you know it for for OB, you kind of know it for her, honestly. She doesn't go too like in debt. I think she probably goes in debt more with like she honestly asks you about like which ones do you report to the CDC, and like you know it's the evil twins, right? Chlamydia and gonorrhea. Um yeah, the STI, the like the infections, all of those like you kind of already saw them. Um for this right here, you see how it's highlighted? You better know that. Again, here's I was in line what sanguineous and serosanguineous means. Um, for just know which ones like cause infertility or stuff like that, you know, because that's stuff that you might want to relate to your patient. For cancer, um, let me see. Oh, McKenna, you have an iPad? Like screen record, girl. Okay, for cancer, I think she has something about oncogenes. Know what like malignant and benign are, and then which ones can turn into cancer or not. Like, you know, the skin ones, like BCC and squamous, all of those. Um, Cancer prevention, know your staging for cancer. Um, what else? Oh yeah, know your nadars for sure. Um, know what it means. Okay, you never give two of the same uh you never give the two of the two drugs that have the same nadir, okay? Because that's your lowest, like that's when the medication's at the highest, but your system and your blood counts, that's like the lowest. Your body is actually the weakest, but the medication's at its highest. So if you give a patient with both of them have the nadir of like let's just do 7 days. Like you're gonna kill your patient because you just wiped out their immune system. Okay? Um, Neutropenic precautions for cancer, know that. Hematopoietic stem cell. Um, I think the one it's like stem cells to restore your bone marrow after treatment, right? But the main thing you want to know is graft versus host disease, and that is so normally you have um like the rejection, like your body rejects this. This is the opposite, okay? It's like your donor cells are attacking the cancer cells. Okay? So opposite with this one. Um, and it's important because it can lead to death. So it's not your body rejecting it, it's the transfer. Yes. Everything that's in red, I would kind of pay attention to, okay? But for the most recent material, like you really do have to know it because it's where your money's at. Benign, so breast disorders. Oh gosh, I think I told you guys already. I did not like this lecture. It was way too long. Tenderness, know the differences, know when to do and how to perform breast exams, breast self exams, okay? So it's gonna be like same after, is it after or before your period? I should test you guys. Mm-hmm. And it's gonna be the like same tons. You want to do it consistently, okay? Like you're not gonna do it like day four and then the next time you're gonna do it like 2 weeks after. No. Um, and I just always think like when you're menstruating, no. when you're menstruating, like you're like some women experience like PMS, and like some of it is like breast tenderness or like swelling. So it wouldn't make sense, like to me, I think about like it wouldn't make sense to do it before because it's not gonna be, accurate, if you will. Oh, stop it, you guys. You guys are gonna do good. Oh, for the breast cancers, really know the difference between them. There was so many like infiltrating ductal, know which ones are like okay, like they're which ones pose most risk and which ones are like okay. If you're gonna have one, this one's not too bad, right? Um, the thing with this one, and I said it last week too, know your risk factors. So, right, so your biomarkers, so the HER2 or the BRCA2, BRCA1, BRCA2, um, understand what those are, okay? Um, and then BRCA, it's like BR for BRCA, and then the C for can't the C, right? That's how I remembered it. Sorry if I didn't tell you guys that last time. And then what it looks like. So what is normal and what is not, okay? So what are like worrisome and what are not? Like some are just part of aging and all of that nonsense, all of that jazz. And some of them are, yeah, yeah, exactly. And she'll give you a scenario where like, oh, the patient describes like something that feels like it's squishy, like stuff like that. Okay. Um, see, you got this. You guys play too much. Okay, and then targeted therapies for like each type, okay? Um, what else? Chemo prevention, so know your medications here. I think she likes tamoxifen. And then, oh, here it is, the self-screening scan, right? Because you're looking at like what's gonna help my patients, like it's preventative, right? This is preventative stuff. Um, know when you start them, when you do them, and then when like if you're high risk, you're gonna do them every year, okay? Anything like that. So really know your guidelines here. Um, again, I wasn't lying. Tamoxifen, you should know that. Um, diagnostics, gold standard, it makes sense, right? Cancer, you want to take a piece of it and make sure if it's malignant or benign. You want to know what staging means? For the lymph nodes, you need to understand that if there's a lot of lymph nodes with a little bit of cancer, it's worse than if only two lymph nodes have a ton load of cancer. Why? Because think of your lymphatic system, it's all over your body, right? So if you yeah, Sean, no worries. Honestly, if the screenshots aren't working for you guys, if you guys have like an iPad or something, like just screen record, honestly. Um, if you so yeah, so understand that your whole body is like your lymph nodes go all over your body, right? So think about it. If you have a little bit of cancer and a lot of lymph nodes, you're kind of tanked right there, right? It's a recipe for disaster. Versus if you only have two or one lymph node with a ton of cancer, it still hasn't spread. It's still pretty like quote unquote contained to only two lymph nodes, so they can remove those two lymph nodes, right? And do kind of like um contain it as much as possible. So that does come up. When she explained it, I was like, what? But it's okay. If I got it, you can get it. Understand like the lymph node biopsy and what it does. Okay, so the centennial and the axillary. So yeah. And then education. This one was so important. You guys, especially for cancer, for breast cancer, you want to tell your patient what they're allowed to and what not to do. Okay, so um, bone marrow suppression, yeah, neutropenia precautions, all that. Just, I mean, this makes sense, right? It's cancer. And then there's some stuff super highlighted there, so pay attention to that. Um, I don't know what happened here, but anyways, show must go on. The radical is like the one that like, I mean, it's in the name, it's radical, right? Oh, sorry. Yes, Sean. And then lymphedema prevention, range of motion. Okay, keep it light. Post-op information you want to do, monitor JP drains. Okay, and I think that was it. Okay, we're gonna scroll to the top. Do you guys, are you guys struggling with anything? Like anything I can answer? I'll put my name in here too. My name. Oh my gosh, you guys, I'm done. When I say I'm done with this quarter, I really mean it. Um, Here's my phone number, and if you guys have any questions. Okay. All right. Are you guys ready for to just scroll? That's pretty much it. But again, like really, really understand the last lectures, okay? Um, if you don't have, if you're like crunched on time, I would. All right, let's go. You guys are gonna do good. But honestly, if you find yourself struggling and you need to retake ATI, I would watch those videos. I mean, be sleep deprived. I honestly have gotten 3 hours of sleep every night. So you just sacrifice and move on from the quarter. From next quarter? What do you mean? Like these notes? Oh, possibly. They say we can't, but I don't know. Everybody says we can't. It's like not allowed. I'm like, okay. What am I spilling? I have heard someone got in trouble though for doing that, so can't say it. All right. Next up, you guys are good, right? I'm gonna just show you the ATI stuff. Oh, hold on. Let me make sure I get all of you guys. I don't want to scroll. Um, oh, snaps. Hold on. I can't see the. Oh no. What did I do? Technical difficulty. Sorry, guys. One moment, please. Oh, what in the world? I'm so sorry, guys. One second. Okay. Can you guys see? Don't forget to put your name. Okay. All right, let's rock and roll so we can all go to sleep. I swear some of these questions came up, so and I looked at this like the morning of. Don't be like me. Maybe like review them today before you go to bed. So your mind can like recall. But 18 has so many questions, you guys. It's like 18, right? I do remember like the anything with like drains, like do they have to be above, below, heart level, dependent, all that jazz, right? I think the ones that are highlighted are the ones that like I kind of remembered. Okay, that's all I have for ATI. Everybody got it? Anybody have any questions at all? I think you guys might have one last study group, right? With your other study group leader. Um, oh, you're so sweet. Thank you. I tried my best. Um, if you guys don't have any questions, have a good night. You guys have my phone number if you guys need help or anything. Just let me know who you are. Otherwise, I won't respond. Have a good night, guys.